introduce us. So welcome, everybody. Thank you for joining us today. I'm Sharon Anderson, president of Leiomyosarcoma Support and Direct Research Foundation, or LMSDR. And I'm also a 23-year uterine LMS survivor, stage 4. So I'm happy to be here. I'm happy to see all my fellow members here. I know most of you from over the years. And today we're really, really excited to have Dr. Alison Schram from Memorial Sloan Kettering come and share her research on PARP inhibitors and the BRCA2 mutations in LMS. So welcome, Dr. Schram. Would you mind giving us a little introduction to yourself?
Yeah, absolutely. Well, first of all, thank you for inviting me to come speak today. I'm, as you said, I'm Alison Schram. I'm a medical oncologist from Memorial Sloan Kettering Cancer Center. My main focus is on clinical trials and early drug development across solid tumors, particularly in molecularly targeted therapies. So, genetic testing and molecular profiling helps inform decisions about our therapy, and that's really what I focus on. I also do GYN medical oncology, so I treat patients with uterine leiomyosarcoma, among other gynecologic malignancies. So I'm hoping to forward that field as my aspirations. And today I will be talking, as Sharon mentioned, about PARP inhibitors in patients with BRCA alterations. And I can share my slides here to get started.
Great.
So can everyone see this?
I can.
Perfect. All right. Well, again, thank you for having me today. So these are my disclosures. So to start, just introducing PARP inhibitors. PARP inhibitors are, I guess starting at the very beginning, when cells divide or are damaged, they develop breaks in DNA. And this happens every time our cells divide. There's a certain number of genetic breaks that happen. And the PARPs are a family of enzymes or proteins that repair single-stranded DNA breaks. BRCA1 or BRCA2 loss of function mutations result in a lack of homologous recombination. So homologous recombination is a form of DNA repair, and when there are genetic mutations in BRCA1 or BRCA2, this form of DNA repair can not go on as it typically would. So this makes the cell unable to repair the DNA damage that has accumulated in the presence of a PARP inhibitor. This overwhelming DNA damage leads to cell death in BRCA-mutated cancer cells, but not in normal cells. So you see on the right a schematic. This is a bit complicated to wrap your head around, but this schematic is really, PARP inhibitors cause these single-stranded DNA breaks. They're unable to repair single-stranded DNA breaks if you have a PARP inhibitor. And then ultimately, that single-stranded DNA break turns into a double-stranded DNA break because it hasn't been able to be effectively repaired. The double-stranded DNA breaks would usually be repaired by homologous recombination, but in cells that don't have functional BRCA, this can't happen, and so the cells undergo death. In normal cells that have functional BRCA, the DNA is repaired and the cells are able to continue to divide. So in that way, PARP inhibitors are selective for cancer cells in patients that have BRCA mutations in their cancer. The strongest data for PARP inhibitor use is in the treatment of cancer, comes from studies involving patients with BRCA1 or BRCA2 mutations. So PARP inhibitors are approved in several diseases characterized by germline or inherited BRCA mutations. We call these the BRCA-associated tumors. This includes ovarian cancer, breast cancer, prostate cancer, and pancreas cancer. What happens here is a person can be born with one abnormal BRCA, but we have 2 copies of our DNA, and so their cells are able to divide as normally. But if there is, statistically, they're more likely to get a second hit in their DNA so that the second strand of DNA is not functional, and then BRCA doesn't work. And so then these cells are not able to repair DNA effectively, and they turn into cancer. In uterine sarcoma, inherited BRCA mutations are exceedingly rare, but we are finding some use for them, as I will describe in just a minute. So just to give you, I don't need to give this group too much of a background on uterine sarcoma, but Nonetheless, uterine sarcomas comprise about 1% of all gynecologic malignancies and 3 to 7% of uterine cancers. The first-line treatment regimens for advanced disease include doxorubicin and trabectedin and gemcitabine and docetaxel. Single-agent chemotherapy is often given once the cancer has progressed on these agents, although there remains room for significant improvement in outcomes. And so we're always looking for better therapies for our patients. Homologous recombination alterations or genetic alterations occur in leiomyosarcoma, and you see that there's an enrichment in HR mutations in LMS compared to other sarcoma types. So this is a retrospective study looking at genetic alterations across different sarcomas. And in this trial, they defined homologous recombination alterations more broadly than just BRCA. You see this long list here, but they did separate out BRCA and non-BRCA HR pathway mutations. And what you see is that in leiomyosarcoma, there's far more HR pathway mutations than in liposarcoma or other sarcoma subtypes. So clearly an enrichment in HR homologous recombination mutations in leiomyosarcoma. And you see here BRCA2 pops out as, BRCA2 loss, meaning you've deleted both copies of BRCA2 in the cancer. That seems to be enriched as well in leiomyosarcoma. So now, that same study looked more closely at the leiomyosarcomas and said, does it depend on where this leiomyosarcoma comes from? And they compared uterine leiomyosarcoma to non-uterine leiomyosarcoma. And what you see here is that it does matter. So BRCA loss is far more common in uterine leiomyosarcoma as compared to the non-uterine leiomyosarcomas. And there are non-BRCA homologous recombination alterations in both. You see, 10% and 13% listed here, but it's clear that BRCA seems to be more common in the uterine. So are PARP inhibitors useful in BRCA-altered uterine leiomyosarcoma? This is a very logical question since we've noticed that these cancers have BRCA2 loss. And I'd like to differentiate from the BRCA-associated tumors that we talked about. And in some cases, those, as I said, one of the alterations is inherited and the other happens by chance. But in the uterine leiomyosarcomas, these just are random events that happen in the cancer. So these are not inherited mutations. These occur in the tumor itself. So this is sort of a different pathway to lose BRCA than the current indications for PARP inhibitors. But to answer this question about whether PARP inhibitors can be useful in BRCA-altered uterine leiomyosarcoma, we have to turn to something called a basket trial. And so to answer questions about rare genomic alterations and rare diseases where we can't study we can't effectively study the question because it would take too long to enroll patients to these trials, we've turned to something called a basket trial. And on the right, you see a depiction of what that is. As you know, different genetic alterations can occur across different cancers. And we are now using these molecularly targeted therapies that are rational in patients that have a specific molecular alteration, perhaps regardless of where the cancer came from. So we take patients who have a certain genetic alteration, and it doesn't matter if it's melanoma or prostate cancer or sarcoma, but if they have the target, then they're enrolled in a clinical trial. And this allows us to study rare tumor types like leiomyosarcoma. So historically, anti-cancer therapies were studying it in these disease-specific clinical trials, including studies of molecularly targeted therapies, but more recently, in large part because we're doing increased molecular profiling across cancer types, we're able to do these basket trials. This is an example of one such basket trial that I helped to lead that was a combination of avelumab, which is an immunotherapy drug, with talazoparib, which is a PARP inhibitor. And this was a basket trial enrolling patients across many different solid tumor types who had BRCA-altered advanced cancers to get this combination. And the rationale for the combination with immunotherapy and PARP inhibitors is a bit beyond the discussion today, but I do think that the results of this were really exciting from a leiomyosarcoma perspective. This figure is very tricky to read, and I'm not expecting you to understand it all, but I think the major kind of take-home message is that you see that each of these bars is an individual patient, and the x-axis here is months. This is the amount of months that the patients were on the study. And the colored bars represent the different tumor types. And you see on the right, there's a little key for what the different tumor types were. This dark maroon color that pops out is uterine leiomyosarcoma. And what you see from this trial is we enrolled a lot of different patients from all different solid tumor types, but all 3 patients with uterine leiomyosarcoma had prolonged responses that were ongoing when we wrote up the study. So out of all of the different cancer types, this really floated to the top in terms of the most exciting potential for PARP inhibitors in combination with immunotherapy of all of the diseases that we observed. And this is one particular patient of mine who is, I think, an excellent example of the potential for this treatment. So absolutely lovely 67-year-old woman who was diagnosed with uterine leiomyosarcoma. She had her ovaries and uterus out and unfortunately developed a vaginal cuff recurrence and then multi-site recurrence. She was treated with resection, a second surgery, followed by hormonal therapy, but unfortunately that didn't work for very long, and she developed recurrent peritoneal implants and abdominal wall metastases. At that point, she started chemotherapy with gemcitabine and docetaxel, and she was on the treatment only for about a month before developing disease progression. So this is an extremely aggressive cancer. At this point, we had done her genetic profiling and noticed that she had a BRCA2 loss and enrolled her to this clinical trial that was available at the time. And it was a colleague of mine that was running the study and put her on the trial. And as you can see, she had a really exceptional response to the treatment. The top here is showing her disease course, and the bottom is showing what we call the tumor volume. And that is the way that we do that is we take a scan and we take a couple of reliably measured spots on the scan and then sum them up. And then with each subsequent scan, say, what is the percentage change from baseline? And what you can see is that she developed a dramatic response to the therapy and actually a complete response where you could not see any visible cancer. She has now been, eventually we stopped the immunotherapy because she had no evidence of cancer for a very long time, and we didn't think it was necessary for her to continue coming in every 2 weeks for infusions. And now she's continuing on the pill alone, the talazoparib, and has been on this therapy for over 7 years. And I've actually been trying to discuss with her whether or not to stop it because she is very likely cured of her cancer. This was a couple of cases from this basket trial, obviously very exciting, but small numbers. And so looking in the literature, what else can we find? There was a study that looked similarly retrospectively and saw that there had been 4 cases of patients with uterine leiomyosarcoma that were treated with PARP inhibitors. These patients didn't have quite the dramatic response, but still, for this aggressive disease did very well. 2 of them had stable disease that lasted for over a year. 1 had a partial response that had been only ongoing for about 2 months, but it was early in the patient that was still on treatment. And another patient who had very, very slowly growing disease on this therapy, but again, over a year. So this is really a good outcome for uterine leiomyosarcoma. But we really didn't know how many, what is the actual, response rate? We don't have a good denominator in a large study to understand how well this works because, of course, my incredible patient case can't be everyone, and we really wanted to understand how likely is it that you're going to respond to this therapy. So I looked at Sloan Kettering's data to describe all of the patients with uterine sarcomas that had sorry, it's advancing here, that had BRCA mutations. And we found 35 patients that had BRCA-altered uterine sarcomas at Sloan Kettering. The demographics are shown here. Patients had different ancestries and races. The majority of these patients had leiomyosarcoma, although there were some adenosarcomas and high-grade endometrial stromal sarcomas. The majority were ER positive, although not about half, a little more than half. And they were diagnosed with varying degrees of extrauterine involvement, but the majority were non-uterine confined. Most patients all patients had surgery at some point in their disease course. About half had radiation, and about 90% had some systemic therapy. The majority having had chemotherapy, about half having had hormonal therapy. And in our series, 43% had a PARP inhibitor. So that was very helpful for us to be able to go back and look. And you see on the right just the different BRCA alterations. The most common were these BRCA2 deletions, which I mentioned. This is an oncoprint. It's a figure that shows what are the other genetic alterations that the patient has, and also looks, by disease type. So the top, you see histology with the colors. What you can see is the vast majority of these patients had leiomyosarcoma. Sorry. And the response to PARP inhibitors, yes, no, these the little black boxes at the top had responses to PARP inhibitors. So what you see is that really it was the uterine leiomyosarcomas, predominantly with the BRCA2 deletions, that had responses to these PARP inhibitors. And if you look of the 13 uterine leiomyosarcoma patients treated with PARP inhibitors, this is again a swimmer plot. So the x-axis is the time that they were on the treatment. And you see that the overall response rate, meaning the significant, more than 30% tumor shrinkage for at least 2 scans, so that's what we consider a response, was about 46%, and clinical benefit rate was 62%, meaning that patients remained on this therapy for at least 4 months. The median progression-free survival was 13.2 months, which is more than a year, which is really exciting for this disease. And the median progression-free survival ratio was 1.9. And so the ratio is the ratio of how long you've been on this therapy compared to the therapy just prior to this. So what that means is that patients, it's using yourself as a control and saying that you were on this therapy for longer than the previous therapy, which we use as a surrogate for benefit. And it actually, in order to count, you have to have been on it by the ratio has to be 1.5. So you have to have been on the PARP inhibitor for at least 1.5 times the previous therapy. So, one of the main questions that we get is, can non-uterine leiomyosarcoma patients benefit from PARP inhibitors? And truthfully, it's hard to answer that question because BRCA alterations are rare in this population. Non-BRCA homologous recombination alterations are more common, as we mentioned, but there's really little data on these patients to answer this question. There's only a few studies of PARP inhibitors in non-uterine LMS, and the full genomic data is rarely available. So what you see here is a paper from one of my colleagues, Dr. Mova, who I believe has previously had been presenting on this same forum. And she looked at a combination of PARP inhibitors and another drug in patients with leiomyosarcomas. And what you see is that the vast majority of patients that she enrolled were uterine leiomyosarcoma. So only 3 patients were enrolled that didn't have uterine leiomyosarcoma. And the patients that there was a clinical benefit noted in 2 patients, one with uterine LMS and a BRCA2 deep deletion, and another patient with stable disease. Both of them had uterine LMS with BRCA deletion. So really these are anecdotal cases across many different trials, but there does seem to be a clear trend for uterine LMS and BRCA2 deep deletions as being the combination that may be most beneficial, although definitely more data is needed to understand whether these non-uterine LMS patients can also benefit from PARP inhibitors. So in conclusion, PARP inhibitors demonstrate promising efficacy in patients with BRCA-altered uterine LMS, particularly with these BRCA2 homozygous deletions. Our findings support the importance of NGS testing, which is next generation sequencing testing or DNA testing in this population for appropriate patient selection for PARP inhibitors. And additional data is needed to determine the added benefit of immunotherapy to PARP inhibition, and also whether PARP inhibitors are a good choice in patients with non-uterine LMS with BRCA2 alterations or uterine LMS with non-BRCA2 alterations. Thank you for your time.
Thank you very much. That was a lot. So let's see if we can digest it and pick it apart. So people have questions. My first question is, do men also have the BRCA2 deletion, or can they? Would be the better way to phrase it.
So that's a great question. BRCA, some male tumors do have BRCA deletions. Prostate cancer is an example of one where you see inherited BRCA alterations. Those are usually not the deletions, but those are usually mutations. But you can see BRCA deletions in prostate cancer, also in male breast cancer. So yes, absolutely. We do recommend, DNA testing for all solid tumors, and there are definitely men, both, pancreas, prostate, and other diseases that can have this.
Good to know. Good to know. Anybody have questions? Kathleen.
Thank you for presenting today. I have two questions. One is, my understanding is that if you have multiple reoccurrences, the tumor DNA can mutate. So if your first tumor doesn't show a BRCA mutation, for example, I've had four taken out, 4 different open surgeries and LMS tumors removed. Could it be in the next one?
Yeah, no, that's a great question. Some clonal evolution, we call it, is when, the cancer DNA changes over time or over space. And that definitely does occur. Looking at our cases, it seemed like the cases that we had were there from the beginning and remained. So they were probably what we call truncal, which is something that was part of the initiation of the cancer. And so I think it's unlikely to develop a BRCA2 deep deletion in a metastasis if you've not had one from the start. That being said, there definitely can be new changes that emerge over time, and it's never a bad idea to check and see what do you have now.
Thank you.
Great. Emily, did you have a question? I think I saw something in the chat.
Yes, I read Dr. Schram's article that she recently put out, and I wonder if she could talk more about combining immunotherapy with a PARP inhibitor. It seemed like in the article that makes a PARP inhibitor more effective, but I was wondering, is that true? And then also if like your tumor is cold or doesn't express PD-1, I think, does the immunotherapy also help with a PARP inhibitor?
Yeah, so thank you for that question. It is one of the very important questions in our field. There were a couple of papers that came out several years ago suggesting that the combination of immunotherapy and PARP inhibitors together could be very effective. There's a lot of different mechanistic rationales for that. One is that PARP inhibitors cause more genetic alterations, which cause more abnormal proteins in the cancer. So the immune system is more able to recognize your cancer cells as foreign. There's also some inflammatory pathways that crosstalk between the two so there have been several trials in breast cancer and ovarian cancer across different diseases looking at this combination. I will say that my impression is that the jury is still out, although these large trials in breast cancer, for example, and ovarian cancer have shown exciting results with the combination. It's not clear to me that it's what we call synergistic, so better than just if you added the two results together of the monotherapy trials. So I think it still remains an open question, truthfully. In our patients, it does seem like for uterine LMS, this combination was very good. But again, we don't have these large numbers of patients treated with one monotherapy, just the PARP inhibitor, to compare the combination of immunotherapy and a PARP inhibitor. In an ideal world, I would love to run that trial where we compare the effectiveness of the combination versus the PARP inhibitor alone. But based on the rarity of uterine LMS and the even more rare subgroup of BRCA-altered uterine LMS, that's just not a practical trial to run.
That makes sense. We have some questions in the chat. I don't know if you can see them, Dr. Schram. But
Yeah.
Mark asks, why do you think there would be a difference between non-uterine LMS for the response rates that have BRCA2 loss and signature 3 with, oh boy, Atrex, and I don't even know how to call BRD4. How's that? Similar to LMS mutations, it seems like the logical target still when there is a weakness.
Yeah, so if I'm understanding this correctly, I think the question is why BRCA2 and not these other genetic alterations that also cause loss of homologous recombination in terms of the output is that you can't repair your double-stranded DNA breaks. Truthfully, I don't know. I mean, I think there's a couple of things. One is that I think we need more information. We need more patients with, ATRX and other homologous recombination abnormalities. enrolled on these studies, we then need to do really good translational work looking to see how common is signature 3. Is signature 3 really all there is to it? Or, sometimes here at Sloan Kettering, we don't just look at signature 3. It's more of a complex signature to look for responsiveness to PARP inhibitors. So we had initially thought signature 3 really was the answer, but maybe there is a more specific genetic scarring, pattern that we can use to understand the absence of homologous recombination as a phenotype. So I think we really need to enroll more patients with other HR alterations to understand whether PARP inhibitors are effective in that population. It's tricky. A lot of the studies try to do this, but they get a handful of different alterations, and so I think the jury is truthfully still out, but it may be that there is more to the mechanism of action than we initially thought, and that it's not just all about signature 3 as a marker. Okay, let's see.
Thank you. Sorry, Sharon, thank you so much for trying to translate my complicated writing as well. I appreciate it. One question as well. Do you have any theory on the non-uterine, now it's my turn, so BRCA2 loss? Do you have any theories why it would be different, I suppose, the response rate? I know they're so rare, but they do exist. Do you have any theory there, or?
Yeah, so non-uterine BRCA loss. So in patients that have, for example, breast cancer, ovarian cancer, prostate cancer, pancreas cancer, PARP inhibitors are very well validated. They're FDA approved. And that is both in patients that have germline alterations, but also, depending on the specific indication, in patients that have somatic and BRCA2 loss. So those definitely do occur. We see them in those diseases as well. There are what we call a long tail of other patients. So you'll see a patient with lung cancer with the BRCA loss or another disease. And it may be that some of those patients really do have deficiency in homologous recombination and would respond to PARP inhibitors. But sometimes those seem to be more like passengers. They are not, if it's true homozygous deletion, that's usually really resulting in a loss of the protein function. But if you see just like a missense mutation or other genetic alterations, it may or may not actually impair the function, and it might be more of just a passenger, I would say, and not truly functional. So there's a lot of ongoing studies looking at that, but it does seem like certain diseases are more susceptible to getting these BRCA alterations, and that those same susceptible diseases seem to be more sensitive to PARP inhibitors. So there is something definitely biologically there. However, I think the uterine LMS story really teaches us that we can't stop with the BRCA-associated tumors, and there are probably other cancer patients and cancer types that may also be uniquely sensitive to this therapy.
That's great. Thank you. Let's see. Mark, did we get all your questions? I see you have a bunch in the chat.
Yes. Yeah. So another one for me is, we talk about in the group sometimes, is following chemotherapy with the PARP and immunotherapy, because there's already damage done by the chemotherapy, have a good response. Do you have a view if that's the best time to go on to this combination? And obviously that's used in other cancers where they do chemo first and then move on to immunotherapy and PARP combo.
Yeah, so PARP inhibitors are used, as you're alluding to, as maintenance therapy in some diseases like ovarian cancer. The reason that, to my knowledge, the reason that the PARP inhibitors were developed in that way is because we initially wanted to combine them with chemotherapy, but it was just too toxic because they both cause cytopenias, and together that would have been too toxic. So it was given as a maintenance therapy. In terms of, what would be better, to give it as a maintenance therapy after chemo or to give it by itself, it's really tricky. It depends, I think, patient by patient, case by case basis. Looking at our retrospective cohort, there was one patient who received PARP inhibitors as a maintenance therapy. But the tricky part is it's hard to know, if you received it as a maintenance therapy, if it's working. So you don't have, for ovarian cancer, we have these large randomized control trials that say using it in this way is effective. But in uterine LMS, we don't have that data. So in someone who has no evidence of cancer, or they have evidence of cancer, but it's been effectively shrunk by the chemotherapy, if you put someone on a PARP inhibitor, it's hard to know whether it's working, if the cancer is not growing because of the chemo or if the PARP inhibitor is working. That is in contrast to if you give it when the cancer is growing, you have a very clear signal. Well, is it shrinking or not? And so in the sense that this is still relatively new for uterine LMS, it's the cleanest way to do it is by, when the cancer is growing and you need a new therapy. But in a very aggressive disease type, if you've had the cancer grow despite standard therapy, now you've had a chemo or you've had a surgery, I don't think it's unreasonable to try it as a maintenance therapy.
Great. So Gwen asks, my uterine LMS tumors have FANCA mutation. My oncologist wants to start me on a PARP inhibitor because FANCA is a BRCA-like in its molecule role. What is the state of research using of PARP inhibitors for mutations that have similar role as BRCA?
Yes, so that is also an active area of research. Those are the other HR mutations that we were talking about in the presentation. They have been underrepresented on these clinical trials of PARP inhibitors. There have, the leiomyosarcoma paper, the last one by Mova et al., did enroll patients with other HR alterations, and it was only the BRCA ones that benefited, but again, it was really small numbers. So I don't think we have sufficient data to be able to tease out, well, what about the FANCAs versus the RB1s versus the RAD51s? These are just so rare that it's likely that we can't group all of these things together and say it doesn't work. We would need to study each one individually, but the numbers are too small to really do that. So
okay, so Robin asks, is there a benefit to combine PARP inhibitors with a maintenance trabectedin? But I will add to that with any cytotoxic chemo.
So, as I mentioned with the ovarian cancer experience, it can be tricky to combine PARP inhibitors with chemotherapy because they both, generally speaking, although different chemo is different, but they generally cause overlapping side effects. So things like lowering of the blood counts, in some cases GI side effects or fatigue can be issues with both. And so it has been challenging to combine PARP inhibitors with other targeted therapies and other chemotherapy for that reason. There are some ongoing studies looking at combinations with, for example, temozolomide, which I see in the chat here, which perhaps has a slightly different side effect profile. And I know that those studies are happening, but I haven't seen any, I don't think we can really compare the results to PARP inhibitors alone at this point. So I can't say it's more effective or less effective, particularly in this rare population.
And how about side effects of PARP inhibitors? What are they?
Yeah, so the side effects are mainly lowering of the blood counts. It can cause anemia, which can cause you to feel tired or have some shortness of breath with exertion, rarely require a transfusion, thrombocytopenia, which is lowering of the platelets, which can increase the risk of bleeding, and neutropenia, which can increase the risk of infection. The rate of cytopenias varies depending on the PARP inhibitor that you use. So for example, niraparib is a PARP inhibitor that's more likely to cause thrombocytopenia. There are many different PARP inhibitors. They all have the same flavor of side effects at slightly different rates. They also cause GI toxicity, and so that's typically nausea, maybe decreased appetite, change in taste. My experience is that is usually the worst for the first 2 months that you're on the therapy, and then it actually gets better with time. So patients, I say, if you can take anti-nausea medicine for a couple of months, it's probably going to get better with time. And the other side effects, fatigue, usually it's not debilitating fatigue. And the one that we always talk about is exceedingly rare, but you can get secondary cancer. So leukemias and myelodysplastic syndrome are two rare but serious cancers that can occur at higher frequency in patients who have received PARP inhibitors.
Thank you. Julie, are you trying to raise your hand or are you trying to fiddle with your computer? Okay, no, okay, we'll go on. So let's see what else is in the chat.
Sharon, this is Jim Bolts. I got a question.
Okay.
So we're Dr. Schwartz from Sloan is at the Cleveland Clinic now, and he's treating my wife, and she just started Lynparza. We're about 60 days into it. and he's one to add a chemotherapy or immune therapy. He claims that this only works on 10% of the people than Parza does. What's your feelings on that? And her uterine tumor is huge. It's 25 centimeters and it's metastasized to her lungs and liver.
So, you know, it's hard for me without more information to be able to answer that question. First of all, I'm sorry about your wife. That's really a tough situation. Do you know if she has the BRCA alteration?
Yes, she does.
And it's uterine leiomyosarcoma?
Yes.
So to my knowledge, we really don't have, you know, the largest study that's been done is this retrospective one that I showed, which had a 46% response rate, but some of those patients were combining it with chemotherapy, with immunotherapy, and that was not a prospective trial. We haven't yet seen a prospective trial where patients with BRCA altered uterine LMS are randomized or even not randomized, even a single arm trial looking at PARP inhibitors. So I don't think that anyone can adequately kind of quote a response rate truthfully. Yeah, so I guess I don't know exactly what statistic he's using there, but there is definitely, you know, there's a lot of research being done right now, and it's very possible. I mean, Dr. Schwartz and Shore is very knowledgeable in this area, and I don't know exactly where that statistic is coming from personally, but I can't say that it's wrong. It really depends on the context and the specifics of your wife's cancer.
Okay. One more question. Do you think it's feasible? Sharon and I talked the other day to take that tumor out at that size. They keep telling us, like our surgical oncologist keeps saying he wants to see it shrink a little bit. It did shrink a little bit on the doc's trabectin, and then she went off of that because her port got infected and had to pull the port, but she was going to take her 5th round, and then she had to get off of it, and now it's screwed back to where it originally was. I mean, we just don't know where to go. We're going to ask him. Like, I already sent a message into him, but we want surgery, but you know.
Unfortunately, yeah, I'm not a surgeon, but also without knowing, without knowing more details about her case, I can't see her scan. I'm not a surgeon, so I can't comment on the resectability, but I would defer to the doctors taking care of her in terms of this information.
Yeah. Yeah, I think that's a good answer. Let's see, someone wants the link to the paper, so I'll get you that. And can you undergo SBRT to target a couple of lung tumors while you're on a PARP inhibitor?
You can. I would say usually we hold the PARP inhibitor for some period of time before and after radiation. There have been some trials that have combined PARP inhibitors with radiation to demonstrate safety. In my clinical experience, I would usually hold it for, I mean, it's up to your provider. So we don't have, there's not a standard here. But yes, in general, I think you can get radiation while on or around the time that you've received PARP inhibitors.
Good to know. Any other questions?
I have a question. I was wondering, with patients who are BRCA2, have like BRCA2 loss of heterozygosity and have deletions, is there any thought about, like if they're having multiple recurrences on PARP inhibitors, like platinum therapy versus like Gemtax, and like if the disease kind of would align more with like ovarian cancer type treatments courses rather than strictly LMS, and just your thoughts on that?
In general, I try to use the data that we have in LMS because ovarian cancer and LMS are very different biologically. So in general, I will use, the chemotherapy that we discussed here. There's a lot of single agent data that we did not discuss. The truth is that, based on the rarity, we don't have a lot of randomized controlled trials comparing different regimens in order to really guide our decision making. So it's really a conversation about, what data is there available in uterine LMS? What are the side effects? And is that something that is acceptable to you? What is the schedule? Taking into account patient preference. these are long and difficult conversations, truthfully, and there's not a straightforward answer to that.
Right. Okay. Let's see. Kim asks if there's any evidence that a PARP inhibitor could possibly interfere with wound healing from radiation.
So there is a theoretical risk that PARP inhibitors can interfere with wound healing, generally speaking. That I don't know of any data proving that, like post-surgery, you continue the PARP or you hold it to show wound healing differences. When it comes to radiation, there isn't really wounds. You know, the way that radiation works is it causes a focal DNA damage in the cancer. And in theory, you actually may want to overlap them because the PARP inhibitor would make it harder for the cancer cells to repair that DNA. So there's a theoretical advantage of actually having them overlap to some degree. That being said, the toxicity, there may be some toxicity, particularly if you're radiating a place that is important for bone marrow production. You might get lowering of the blood counts if you're radiating good bone marrow. So this is not something that, you know, it's something that you'd have to speak with the radiation oncologist and your oncologist about, and probably depends on the location of the radiation, the type of radiation, and other factors like your baseline blood counts, etc.
Question to the audience. Has anybody here been on a PARP inhibitor, and what was your result? Anyone? Oh, Caroline and Emily.
Yeah, I'm on one.
And me, Sarah.
And Sarah. Okay, good. Are you having problems getting your doctor to prescribe it, or was it their idea?
Let's see, I see Dr. Ganju at Stanford, and she prescribed it, and it was hard to get the insurance to take it.
Yes.
So let's see, the first thing we did was we put in a financial aid application to the drug company, and then they provided it. And then once it started working, we put in appeals to the insurance company. And then I'm a grad student in Wisconsin, so I have insurance there that accepted it, but then another insurance didn't. So I think that's a problem because it's not FDA approved.
Right.
That people have trouble, but don't forget that you can apply through the drug company itself for help.
Good to know. Good to know. Caroline, did you have trouble?
Oh, well, I was denied the first time the hospital asked for the drug because of the being off-label for on FDA. But the second time the hospital submitted it, it was accepted. And as anybody probably knows, it is an incredibly expensive drug. But I mean, to go from $16,000 a month to $30 a month, and now the second time it's zero. So that's a good thing. So I've only been on it a month, and so I get scanned in another month, and so we'll see what it's like after 2 months. The side effects have not been very bad. I had a little bit of low red blood cell count, just went down just a tad, and also a little bit of low protein levels. But I'm trying to address those. Had a little bit of fatigue, a little bit of poor appetite, but it's been quite tolerable. But I was so glad to hear Dr. Schram say that maybe that might abate in a couple of months. If it's like, I mean, I've been on aromatase inhibitors for 14 years, and after a while, I mean, it didn't take but like maybe a couple of years before those horrible side effects dissipated. So I'm really hoping that this is the case with this.
Great, thank you. Sarah, do you want to share? You don't have to, by the way.
No, I've been on it since December 2023. I've had 2 small recurrences at sites of prior disease, one treated with SBRT and then another with surgical resection. Actually, the second, the pelvic recurrence occurred while we took a break from immunotherapy. And so we resumed it after that recurrence. And I actually switched out of sarcoma to gyn-onc. I see Dr. Swisher at University of Washington, who has prescribed it and has worked with my insurance to get it, and it's been a wonderful experience because I've had pretty aggressive disease.
Fantastic. These are good stories. So I'm wondering, Dr. Schram, what is the next step for uterine LMS or LMS and these PARP inhibitors?
Great question. I am not aware of any prospective trials looking at PARP inhibitors by themselves or in combination for uterine LMS, but there are many different of these basket trials that I mentioned that are ongoing, looking at PARP inhibitors and PARP inhibitor combinations. I see one of the questions in the chat is with regards to PARP inhibitor combinations. There are a lot of ongoing studies with new targets, things like pol theta or ATR inhibitors or WEE1. There's a lot of different proteins that are important for DNA repair, and there are new combinations being evaluated every day. That is also relevant to another question in the chat, which is clarifying the difference between first and second generation PARP inhibitors. So the majority of PARP inhibitors that are FDA approved, they inhibit both PARP1 and PARP2 that are two related proteins, but they're in the same family, but they are different. The effectiveness of PARP inhibitors is thought to be due to PARP1, and the cytopenia, so the lowering of the blood counts, is thought to be more so PARP2 than PARP1. So these second generation inhibitors are looking to inhibit PARP1 while sparing PARP2 inhibition, with the idea being that you can improve the therapeutic index and make them more effective and less toxic. And those drugs are currently in development. Saruparib is one by AstraZeneca, which is one of the farthest along. And this is something that may be able to be combined with other things more readily than the PARP inhibitors of the past.
Anybody else? Questions? There's some in the chat, if you can read them.
Yeah, the MOMA 313 study. Yep, we are opening that one as we speak. So we in our GU group, actually, that's being opened.
Okay.
Well, thank you so much, everyone, for your time and for your thoughtful questions. For those of you that are having insurance problems with PARP inhibitors, it is now listed in the NCCN guidelines, which are guidelines that are put out for oncologists. And so based on some of the data I showed you and some of the cases we had, that is now part of the guidelines. So if your doctor is having a hard time getting approval, you can ask them in the letter to cite the NCCN guidelines. In my experience, that's very helpful.
Oh, yeah, I didn't know it was in there. That's wonderful news. Okay. Well, Dr. Schram, we can't thank you enough for your time. This will be recorded, so you don't have to share your slides or anything like that. And it'll be on our website. I'll send you a recording to you. I'll email you a recording. But thank you so much. This was very, very insightful. And everybody's doing virtual claps. Yay. Thank you so much.
Thank you, everyone.
We really appreciate you. All right. Bye, everybody.
Thank you.